All right, today we're putting on our detective hats. We've got a clinical case to solve, and our mystery is a really common but often hidden condition, Paget disease of bone. So let's start piecing together the clues.
So, here's our first clue, and it's a scene that plays out in clinics all the time. You've got an older patient, they feel totally fine, but their routine labs pop up with just one weird thing, an isolated high alk phos. So what's on your mind? Is it liver, or could it be bone? This is exactly where our investigation kicks off.
First things first, let's talk about the initial presentation. This is where we find our first and kind of surprising clue.
That's right. Just like in our opening scenario, Paget disease is sneaky. It hardly ever announces itself. More often than not, it's discovered completely by accident, either on that routine blood work that flags the high alkaline phosphatase, or maybe on an X-ray that was ordered for something totally different.
This slide, well, it pretty much sums up that classic picture perfectly. You can think of it as a triad. You have an older patient who feels great, a high alk phos that points to increased bone turnover, and some kind of incidental finding on an X-ray.
Now, while Pagets can technically show up in any bone, it definitely has its favorite spots. It really likes to involve the skull, the spine, and those major weight-bearing bones like the pelvis and the femur. And knowing the location is a really crucial clue, because that's what's going to dictate potential symptoms, like pain, or deformity, or even nerve compression.
Okay, next section, the diagnostic workup. We've got our first clue, so now it's time to actually follow the trail.
So, the key here is to have a solid game plan. A good investigation follows logical steps, right? Ours has 3. First, we dig into the labs to confirm our findings and rule out any lookalikes. Second, we get a whole-body bone scan to see just how widespread this thing is. And third, we zoom in with targeted X-rays to really nail down the diagnosis.
Let's talk about the lab work. We already know the alk phos is probably going to be high, but we also check serum calcium and vitamin D. Why do we do that? Well, it helps us rule out other suspects. For instance, really severe vitamin D deficiency can cause something called osteomalacia, which also cranks up bone turnover and can raise the alk phos. It's a key imposter we need to cross off our list.
And now for the aha moment. This is where we've gathered all the evidence, and we're about to see the definitive proof that cracks this case wide open.
And you know, this is a huge pearl for any trainee to remember. After all the other tests, the final confirmation, our smoking gun, is almost always found on a simple plain film X-ray. It gives us that visual evidence we absolutely need.
And this is our aha moment. Just look at this X-ray. You can see the classic signs right there in the pelvis and femur. See how the bone texture looks all rough and coarse? And the outer layer, the cortex, it's all thickened up. The bone itself is literally expanded. When you see these findings together, that's game over. It's diagnostic for Paget disease.
So now we can officially define our culprit. Paget's disease is basically a disorder of bone remodeling. The normal cycle of bone breakdown and rebuilding just goes haywire. It goes into overdrive, and you end up with bone that's just architecturally a mess. It's enlarged, it's structurally unsound, and it's weak.
All right, so the diagnosis is in the bag, but that leads us to the next big clinical question. Do we treat it or do we not treat it?
Luckily, the decision-making here is pretty clear-cut. We pull the trigger on treatment if there are symptoms, like bone pain, or if the disease is in a high-risk spot, where it could cause a fracture or compress a nerve. We also treat before any planned surgery on that bone. But if the patient is totally asymptomatic and there's no immediate risk, we can just monitor.
And here's the really good news. When we do decide to treat, the first-line therapy is incredibly straightforward and super effective. For most people, it all comes down to a single infusion.
And here are the specifics. The drug of choice is zoledronic acid. It's a powerful bisphosphonate. A single 5 milligram dose given through an IV is often all it takes to get the disease activity under control. It's simple, it's potent, and it's really efficient.
So, let's talk about how well it works. I mean, how long does that single dose last? You're going to love this. In many cases, it can get that alkaline phosphatase back to normal and control symptoms for up to 5 years. That is an incredible amount of mileage from just one treatment. Okay, so we've diagnosed it, we've treated it, but our job as detectives isn't quite over. We have to close the case with a solid plan for long-term follow-up.
The long-term plan is pretty simple, actually. We just check the serum alkaline phosphatase once a year. If we see those levels start to creep back up after we got them down to normal, well, that's our signal. It tells us the disease might be waking up again, and it might be time to think about another treatment.
We don't need to reimage people all the time, but there are some clear reasons to do it. If a patient develops new or much worse pain, or if their alk phos just shoots up, we're getting new x-rays. And crucially, we also image to screen for a very rare but very serious complication, a sarcoma or bone cancer developing in the Pagetic bone.
This quote right here, it just perfectly sums up the main takeaway. It's really the cornerstone of how we manage this today. A single dose of zoledronic acid is a highly effective, long-term solution for active Paget's disease. And with that, our case is closed. We started with just one abnormal lab value and followed the breadcrumbs all the way to a clear diagnosis and a great management plan. It's a fantastic reminder to always stay curious, right? So I'll leave you with this question to think about. What other bone diseases might be hiding in plain sight with just subtle clues on routine labs? Thanks so much for joining me.